It's the first affiliated hospital of Dalian Medical University, and the procedure is done by Professor Yin Xiaomeng. Professor Yin, this is the introduction of Professor Yin. Julian.
Professor Ying, are you here?
各位专家好，那么我是研究
Hello everyone. My name. Also, sorry, I'm Mr. Yang. I'm not Mr. Ying. I'm under Mr. Ying's leadership within same team. Hello, Mr. Yang.
Hello， 你好，尊敬的讲主任，尊敬的
So respected Mr. Jiang and other peers, today, Mr. Jiang cannot be here due to some schedule things, but don't worry, I'm going to explain and report to you about our patients. We also use a PulseCare equipment. I think I need to share my screen, right?
现在不是共享状态吗？大家能看到我的屏幕吗？
So can you see my screen? If you cannot see it, I need to share it one more time. Can you see my screen?
Yes. 可以看到哈，好。
No.
哎，稍等，看不到您耶。
现在看不到屏幕吗？
You cannot see me, right? You cannot see my screen, right? Let me double check. Can you see my screen? We cannot see it. How about now?
You share screen.
这样是不是可以了？
How about now? Can you see it?
可以了。Full screen.
Yeah, I think so. But you need to click full screen. It's not full screen yet.
现在是全屏。
How about now? I think right now it's a full screen. I already click it. Can you see it? Yes.
那我现在开始。
Okay, let me continue.
好，现在这个病例呢
Hello everyone, this is our patient, 44, 44 male. This is actually just within this week, and so the palpitations is more like intermittent. The patient only suffered for 3 months, and so AF has been diagnosed. Patient used a lot of drugs, so we can see that Metalorix and Metropol, and the patient also suffered from the AF and also the palpitations. And for the anticoagulation, so we use other drugs, atosaban. So the patient come to our department. Now we check about ECG. Now you can see we use the patient to do the pulse, because we know these patients have some the premature contractions and the premature beats. Now you can check about here, Doppler. So the left atrium is bigger, and but the actual the cardiac function is normal. And now here, so you can check about the CD. So quite normal structure, which means the patient is more suitable for the ablation. So during the surgery and operation is very first time for our try the PulseCare equipment. Definitely we perform according to the protocol. And we have done the 12. So 12 ablation for LSPV, 12 for the LIPV, and the patient is quite young, only 44. So that's why total ablation is 54. Just a local anesthesia under 30 minutes. Generally speaking, the smooth ride. And now let's show you more information. So this is about sedation, deep sedation. We make some changes. Now the patient is 185 and also the 80 kg and the BMI is 23.4, quite good. So that's why we have used sufentanil and also ramazolam. And for the sedations, well, to be honest, ramazolam is a little bit larger. Of course, we do recognize that. And for our anesthesia expert, we also get our anesthesia protocol for the radio ablation. Previously, we also use a deep sedation. We want to avoid the general anesthesia, so that's why deep sedation is what we used. Generally, we don't want the patient to remember the painful experience during surgery. And during the ablation for this patient, you can see that patient have not reported some stimulation, whether it's pain, stimulation for the muscle, for other parts. It's actually under control, to be honest. You can see this is here. And for the rotation, I think a lot of experts have mentioned it. And since the patient suffer from the sinus syndrome, now you can see this is how we're going to deal with the rotations. For the other, like a firewall, so you only use like one rotations to cover it all. However, it's more than nanosecond, so that's why the ablation area is more narrow. So that's why we want to make sure the ablation have a close contact and also a better control and cover of the ablation belt. That's why we asked for the 2 ablation. This is one difference between the PulseCare and the firewall. Now you can see this is the same part. We suggest you to have the transceptable puncture in the front part, so that you are going to be guided. The guidewire are going to reach the right lung, right lower lung. You can see. Now you can see here, this is our guide wire, and the needles is more like quite close to the top part, so that's why we can avoid unnecessary risk in the right lower part, right lung part. Now you can see we use the InSight to meet with the 3D, so that when we have the modeling, and we're going to see the information better. And now during the ablations, you can see this is how I have some protections for pacing. Now you can see after the construct agents and also the modeling, you can see this process, how we have the modeling in the system. So we focus on 2D because of the guide wire in the front part. So, and also we need to have some re-entrance and also some basket changes, just like quite similar to the firewall. Now you can see the basket. So after they change the basket, and also the contact and ablation. And also you can see so electric field has been disappeared. And of course, after the electric potentials has been disappeared, we also want to make sure in the other part, so you actually have the better contact, so that you are going to make sure the result are going to be durable. So this is how we're going to do the contact ablation and the potential. And now you can see that we move on to the right lung part. So the lower lung, we do the contact ablations, and also puncture area is quite ideal. It's quite easy for us to reach the right lower lung. Here you can see after surgery, this is the mapping after the ablation. We think the result is quite ideal. We have the better isolation according to our expectations. Here, last part, the sheaths, they are going to move the upper part. We use a basket. Now you can see we have the better isolation after we use the basket shape to have the superior vena cava isolation. So this is SVC isolation. So we just done this patient the day before yesterday. We make the radio, so you can see the last part is SVC isolation. We covered all. Thank you so much for your time and patience. Thank you so much, Professor Xie and Professor Yang. Yeah.
With NxPFA, Nanosecond PFA, and very good.
One question, Professor Xin. Are you always use superior vena cava isolation for all patients? Which protocol are you using?
尊敬的这个
Professor?
尊敬的教授你好哈
Respected Professor, I hear your question. Okay, so for SVC or the superior vena cava, to be honest, for the paroxysmal patients, not for everyone, we only do it for young patients. We do a lot of SVC. The other is HMC. For the rest of them, to be honest, we don't do it always times. We use the burst to have the triggers. And also for the hypotronic cardiomyopathy, we also use it. And so for our center, it's like this.
Can I ask a question about anesthesia? We just saw one of the other cases, and even Dr. Jiang was saying that his protocol typically with this technology is midazolam and fentanyl. But we noticed that in addition to benzodiazepine and a narcotic, you're also using ketamine. And I'm curious, why ketamine? Is it because your experience is different, or this is your normal protocol, or can you just talk about your anesthesia strategy for a minute, please?
Reddy 教授，谢谢您的问题。这个呢，
Thank you so much, Professor Reddy.
这个呢，因为我们在自己的这种麻醉师跟我们
Well, for our anesthesia expert, they collaborate with us a lot. We do a lot of the radio ablation, to be honest. So they also help us to do some catheter ablation under sedation. So that's why you can see we don't always perform according to what the device's requirement asks us to do. We also pivot just according to our experience. To be honest, we use a 7-Danny and midazo is more, so the drug you mentioned. But in the radio, so the radio ablation, we focus on sedation a lot. And so which means femto is more, because to be honest, sometimes we worry about aspiration, so that's why we're quite prudent. And for this pulse, the PFA patients, we are actually just crossing the river by filling the stone, and which means we're exploring. But after recapping, we think the sedation is not enough. We believe perhaps we can use more like a sedation drug. The patient mentioned the pain is not that bad, he can bear with it, but at least their pain. We want to control the pain, although he mentioned the pain is tolerable. Yeah, the other thing you mentioned, let me check about what else you remember it. Well, I think it depends on the anesthesia. What drug they use. It's more like a personal experience. We don't intervene.
And then let me ask you a question about the technology. I remember reading the manuscript. My understanding is the catheter is 9 French, but the sheath is, I think in the previous case, they said it was 12 French. I'm just curious, why such a big sheath if the catheter is 9 French? Or is the catheter bigger? I misunderstood.
您的意思是，我的那个鞘管看起来很大。
So you mean that sheaths look bigger? You mean the sheaths look bigger?
Yeah, I think so, but maybe I'm wrong. Can you just tell me the sizes?
您的意思是我穿间隔的那个
Yeah,
鞘
Dr.
吗？
Reddy, yes. Let me, 杨主任，我来回答。
杨主任你好。
Okay. Dr. Reddy 意思。
Let me answer this question.
讲的是 why the sheath is 9 French, the catheter is 9 French, the profile is 9 French. So why we use a 12 French sheath? Because it's a 12 French sheath is easy to aspirate the bubbles. Otherwise, it's too tight to aspirate. It's maybe cause some bubble embolism. But I think we can try maybe 10 French like that. I think it's also possible.
Very good. You know, the other question is, during the presentation, you mentioned 3 rotations, or 3 positions per rotation, whatever. And you also said, I think, something like the electrical field is a little bit smaller. And I'm curious, what is known about the electrical field? Meaning, in the modeling, for example, how big is the field? Meaning, does it extend forward and backward from where the electrodes are? Do we have any understanding of what the expectation is for what the field would look like?
瑞迪教授，我听明白你的意思了。
Thank
现在您
you,
的这个问
Professor
题
Reddy. Well, for your
确实是目
question,
前这个不管是微秒还是纳秒，
whether
这
it's
是近期的
microseconds
一
or
个
the
热题。
nanoseconds
因
for the
为
pulse
这方面
intensity,
有
yeah,
的我
people
们的这
discuss
个
this a
麦克
lot.
的这个
Well, we
技术
also
人员
try
是比较
to
草根的，
consult with a
它的
technician from the
设计的这个
PulseCare.
是
They told
的
me
原
that
因，
they have the
它
two
还是觉得这个
rotation
能量
is
这
because they
个变
believe
成由微秒变成纳秒，它的一个
when we
这
move
个
from
消
the
融
micro
消
to
融时间要
nano,
窄一些。
so that's
所以
why
他
you need
希
to make
望到
sure
达
the
合适的
ablation
水
is
平，所以他
narrow
通过
because
连
we
续
don't want
的
to cause too
rotation 去覆盖
injury.
圈
So
儿
that's
这
why
种
we use
不
a
适的这
two
个区域。
rotation to
至于
cover the
您
same area
说
covered
这个
by
电场有
firewall.
什么意义
And
呢？
as for the
因为
pulsing,
我
the
们
field
现在可能
intensity,
国际上包括国
well,
内
in the
我们
national
中国内
community
也在这
in
个摸索
China,
的
I think
过程
people
当
are
中，
exploring. So
原
what
则
is a
还是
better
像刚
field
才这
intensity?
个
But to be honest,
线索
or
人
at
教授
least
所
in
说的一
principle,
样，我们还
just
是
like
说
Professor
造成
Xin,
一个永久性的损
what do we want
伤，
to do
那
is
么
to
可
have
能
their
同时
injury,
的又不会造成
the
太多血
permanent
的放
result,
电，那么导
but
致患
don't
者
have
会
too
出现很
much
多的问题。
discharging, which cause unnecessary, damage to the patients.
那么同时这个我们在
Besides,
这个电位消失的同时，还是
when the potential disappear,
根据肺静脉的解剖，包括三维，包括二
you
维，
need to,
去
check
求
about
这个
whether
部
it's
位
a
的构
3D or
造。比
2D
如
to
像
make
我
sure
们
the
中
contact
心
is
先
better.
在脊
In
柱
our
部可能
center,
会多贴一次。
we are
这
going
个
to,
在正常
have
情
the
况下
one
脊柱会
more
多贴一次。
contact in the
在
necessary
目
part,
前的这种器械和
the
电
roof
场
part,
情
I
况
mean.
下， 我们是这么做的，就除
So
了
this
肺
is
静
what we
脉
do.
前庭口部，
Apart
那么
from
有
the
的时候会在
atriums
这个
and entry
脊
part,
部会多贴
sometimes
血液
in
脉
the
背
roof
的呢，就
part,
是去
in the roof
重新的
part,
贴靠
where
和产生足够的这种
the castia
这个是我的一
terminalis.
点
So this
这个
we are going to do
分
extra
享。
contact.
至
So
于
this
说
is
这个
our
强度
experience.
是不是也
But
会
as
有
for the
更强度的
intensity,
强度
whether the
更大的
intensity should go
啊
high,
呢，
ramping
我
up,
们担心更小
well,
一些的强度
well,
更
at
合
least
适的
this
这
is
个流量。
we are waiting and see.
相信未来的这个动物
And
实
I'm
验
looking
我们
forward
将
that in
会给出答
future, the
案。
animal trial and the expert are going to share with me more.
Yes, and Dr. Reddy, according to the animal study, one publication, it will cause 6 millimeter, 6.5 millimeter depth of lesion, and there's about 5 millimeter wider of the lesion. That's the animal study, but we don't know exactly in human being what is different.
Makes sense.
Maybe
Thank you. I think.
Can I have one
Please.
one question again regarding the workflow? And I may have missed it, but during the non-GA presentations and cases presentations, do you have typically also a strong capture of the phrenic nerve while ablating on the right side? And in your very initial experience, have you ever observed a transient stunning of the phrenic nerve as we did with other technologies?
谢谢你的问题，可能是我没有这个，我们在消伤枪的时候，肯定还是要去标测
Well, of
膈
course,
神
you
经的
need to
移位处理。
labeling about
那么这一例病人，
you need to labeling the nervus perenniculus. In these patients, we have not observed the nervus perenniculus some changes. Well, this is the very first time we use a pulse curve, so that's why when we have the pre-cover, we do this part mainly for the nervus perenniculus during surgery or the after surgery. We have not observed something that need our actual attention, but we spot something different. So sinus, we notice like antrinata or the sinus atrial nodes. A lot of patients reported damage in the sinoatrial nodes damage. So perhaps it has been caused during the surgery. So I think what you asked just now is about the nervus perenniculus. We don't spot something like this.
我觉得这个谢谢杨主任。
Thank you, Professor Yang.
谢双人主任还在吗？
Professor Xie, are you still here?
谢主任你还在吗？
Professor Xie, are you online with us now?
Because Professor Xie is a PI of the pre-marketing trial. According to my personal experience, the the capture of the phrenic nerve is very common when ablating the right superior PV, but no patient developed into impaired diaphragm contraction. I don't know. I think it may be impaired, but no paralysis, at least so far.
Okay, I have one more
question. Please.
Yeah, thank you. So it is suggested that nanosecond PFA probably less damages endothelium and also endocardium than millisecond PFA. So are there any considerations regarding post-procedural anticoagulation?
杨主任，你还在吗？
姜老师我在，姜主任。
Yeah, I'm
我在
here. I'm here. Okay.
对。刚才我们外宾的问题，您
would you mind to share your thoughts?
他的问题能麻烦主持人再帮我复述一遍吗？我可能是没听清。
我术后抗敏，他觉得是术后抗敏的问题。
Okay, so the damage. We know that damage will be different. So the post-surgery anticoagulation, would you mind to mention something like this? Any thoughts?
好，谢谢您的问题哈。这我们目前术后的抗凝。
Okay, so post-surgery anticoagulation. No major change between microseconds and nanoseconds. So still anticoagulation for 3 months. I don't really care about the score. 3 months anticoagulation post-surgery. As long as you have touched something, do something to the left atrium's 3 months anticoagulation. Anticoagulation.
对，我看沈志主任在线上。
So Professor Shen Zhi, Professor Shen, any experience you can share? Mr. Shen Zhi is also online.
你好，主任，不好意思，因为我这边声音比较
Hi.
嘈杂。
Sorry, I was in a noisy environment, so I may not catch it too much. But for the PulseCare, you can hear me now?
不好意思。
Sorry, someone has unmuted himself. Professor Shen, we can hear you. You need to unmute yourself one more time. Please unmute yourself. Professor Shen. Professor Shen. Professor Shen.
蒋主任，我不知道可不可以问一个问题哈？现在他们还没上，可能我借这个。
Well, I was considering perhaps I can ask the questions.
就是
For you.
这个脉冲现在不知道您那边可能做的多一些。
I know that you have done a lot of PFA.
包括开会。
I would like to hear your opinion a little bit.
报道的病例其实挺多。就相对来讲多吧。
So, you know, some patients reported sudden deaths or sudden cardiac deaths. I learned this in the news. But I would like to hear your opinions. So, especially for the isthmus. Anything you can share with us? So, have you reported something like this? How to make sure patient is safe? Well, excellent question. Well, today we have invited there's an important expert. I think we can ask the expert to see a few things, but let me start first. And we have paid special attention to a sudden death, yes, isthmus area, especially quite close to the coronary ablation, pay special attention, especially and the other party, if the patient suffer from the coronary diseases, pay special attention. The other thing I want to mention a little bit is, let's see. is not close to coronary. You just so in the pulmonary vein, sometimes patients also reported sudden death. So that's why I pay special attention also to the pulmonary vein and also isthmus. I think in this part we need to, accumulate a lot of experience. It's quite difficult to give you a final answer or the conclusion. Well, our hospital have done 1,000 cases of PSV, and we use a different brand. But to be honest, right now there's no sudden death, coronary spasms, or the ST elevations. We have not reported something like this, but we're worried, to be honest. So this is our concern. So, Mr. Chu.
Melanie, the paper by Melanie published in circulation, it's a very good paper talking about the sudden cardiac death during PFA. So what's your opinion? Can you give some recommendation and opinion on this point? You mute.
Oh, okay. Yeah, thank you. I think we and others observed very, very rare scenarios of unexplained situations after a catheter ablation of using PFA. But with this limitation, having said this, we also need to acknowledge it's also a scenario which we know also with traditional thermal energy sources as well. And but we felt it was still important to collect our initial experience. Overall, the risk is, as I said, very, very low. And we came up in our collection to a risk of 0.16%. And this is a very, very low number. From a technical or from a procedural aspect, we do not change too much, to be honest. We take good care of, let's say, 12-lead EKG to identify changes at a very early point. Patients with a history and known history of Prince metals angina, we are a little more cautious. We are very cautious when ablating close to coronary arteries, even though we still do it and we feel confident to do it. And I think the key question, at least, is to better understand the true nature and the true, let's say, numbers, because the denominator remains a little bit uncertain. And maybe I would like to pass over also to Vivek, because Vivek has started an initiative called the Trace PFA, and in trying to understand the true role of this scenario. And yeah, maybe Vivek, you want to move on with commenting on this topic.
Sure. I mean, look, I think you've said the main important things. There's a very infrequent, rare condition of sudden unexplained death that happens after pulse field ablation. In the Manifest US registry, as well as in Manifest 17K, we estimate the rate is around 0.02%, so 2 in 10,000 patients. So it's pretty infrequent, but still very important when it happens. And I just want to separate the causes. So there's different types of spasm, right? I mean, there's spasm that occurs when you ablate next to a coronary artery. And as Julian said, I mean, I think we understand that. We know how to try to prevent it with nitroglycerin. We know how to treat it with nitroglycerin. But that's different than the spasm, the generalized Prince metal-like spasm that can occur that's somewhat unexplained. Is that the cause of the sudden death? Is it that plus something else, other autonomic influences that cause sudden death? I don't think we know. And as Julian said, it probably happens also after thermal ablation. We were too worried about other things, I think, to worry about that at the time. The good news is that it's very rare. The bad news is that it's hard to study because it's so rare. And as Julian said, we just started an effort, and Julian is part of it, called the Trace PFA Registry, where what we're trying to do is to identify patients, and this is throughout the world, identify any patients who present with this condition, let's call it, of unexplained sudden death soon after an ablation procedure. And the goal is to go very deep and try to collect as much information as we can about that patient, whether they survived or didn't survive, including all the demographics, EKGs, other types of information, imaging information. And hopefully, once we gather a large enough number of patients where this happened, which will take some time, but once we gather that information, hopefully we'll be able to get some ideas, at least hopefully generate some hypotheses that we can be tested prospectively. So that's our goal. And actually, we'll send you some more information. We're going to start publicizing it soon. And hopefully we'll be able to identify patients. Because I think that unless we all sort of band together and try to collect this data, it's going to be very, very difficult to study this phenomenon.
Right, it's so rare. Yes, it's so rare. Thank you. 庞主任，你好。
日本 Japan。
你要说几句吗？
Professor Tang, do you want to see something? I notice you unmute yourself. Yeah, do you want to see something? It seems like you unmute yourself.
你好，你好。
Hi.
对，刚才那个Vivek 在讲就关于
Just now, Professor Reddy has shared something about, the sudden deaths. They got their own registry, on the trees registry for the PSV. Would like to see that. Anything you want to see since you unmute yourself already? So in the PFA, the Nano PFA, anything you want to share? Well, to be honest, no specific thing I want to share, but I really, since just now you mentioned about the coronary spasm, we spotted something recently, and a lot of patients, the coronary spasm just on everyone's lips. They see that sometimes the patient suffer from the coronary spasm in a quite later stage. So that's why we're considering how to prevent it. And then our experience is, how about during surgery, continue to use a nanosecond and so yeah, at least use a natural glycerin and also use it at least 24 hours for the natural glycerin. Yeah, this is our experience. Natural glycerin.
It's very new, and the nano PFA, it's a different. I think one PFA is different from another PFA. So nano PFA, for sure it's different from millisecond PFA, a microsecond PFA. So I think we need to do more research, collect more data to confirm the efficacy, the safety, and everything, and to expand the indication as well. And then because the time is limited, so I'm so glad to see all of you, and thank you, everyone, especially our distinguished international experts like Vivek. Is very early morning, 3 a.m. in the States, and Professor Julian Chun and Professor Mikhaylov, and also our Asian experts in EP field, and our Chinese colleagues as well. I think it's time to let's close this session. Thank you all, and see you in the near future. And see you, Julian. See you in Fafa. Bye bye, everyone.
Thank you.
Thank you. Thank you.
Thank you. Thank you. Bye bye. See you, Ayan. See you.
Thank you, Dr. Long.